My name is Dr. David Rubin, and I'm a professor of medicine at the University of Chicago. In April 2021, I will be the chair of the National Scientific Advisory Committee of the Crohn's and Colitis Foundation. Today, I'm going to be speaking about steroids in inflammatory bowel disease, and specifically some of the recommendations and our understanding about steroids and COVID-19. Although this presentation has been supported by an educational grant from Janssen Pharmaceuticals, and I have previously consulted with them, the content was developed by me and my comments are all my own, as have been all the other slides that we've prepared for this presentation. In inflammatory bowel disease, it's important to remember that the condition is characterized by an overactive inflammatory system. The immune system of the intestines, which is there to protect us, is in overdrive, either because something is continuing to stimulate it or because our body has lost the ability to regulate it or to shut it down or turn it off. Therefore, our therapies for inflammatory bowel disease have predominantly been focused on addressing this overactive immune response. So it's often misunderstood that medications we use that might modify or even suppress our immune system have the goal of causing immune suppression. The reality is that our actual goal is just to turn down the overactive immune response long enough so the body can reset itself and take over and go into a resting phase. It's also nice to remember that the bowel has an immune system that gets activated every time we eat. People who don't have inflammatory bowel disease, as well as those who do, become mildly inflamed with every food item that we swallow and expose our body to the outside world. Normally, the body will then shut itself off, or if we were to get food poisoning or a viral infection, the gut immune system can become much more active. But in people without inflammatory bowel disease, this shuts itself down. In IBD, as I've mentioned, the condition of the immune system of the bowel is overactive, and that overactive immune system is what causes damage to the bowel and causes symptoms that our patients experience who have Crohn's disease or ulcerative colitis. The different therapies we use to treat inflammatory bowel disease can be divided into some categories. You may be familiar with some of the treatments because you've been receiving them, or your family member who has inflammatory bowel disease is receiving them. Antibiotics are used to address certain types of Crohn's disease primarily. They do not suppress the immune system. Aminosalicylates, or sometimes called 5-ASA therapies, or mesalamine or sulfasalazine, do not suppress the immune system either. They are believed to work more topically on the lining of the bowel. Immunomodulators, also considering therapies called thiopurines or methotrexate, can suppress or modify the immune system. These are older therapies that we still use in some patients, and it's important to understand how they work. Steroids will be the focus of most of this presentation, and we'll talk a bit more about them. When it was appreciated that steroids could treat inflammatory bowel disease, it was considered a revolution in the management of these difficult conditions. We've learned a lot more about steroids since then, and I will be teaching you about that. Biological therapies are proteins that have been designed to target certain components of our immune system. They're called biologics because they're actually made by living cells, and then the protein that's made by those cells is used to target other inflammatory proteins in our bodies. There are different classes of biological therapies that work on different targets in our body. Some of them are more systemically acting, where they'll affect the entire body's immune system, and others are more targeted or selective in their activity and have a more favorable safety profile. And lastly, we have a newer therapy that is oral and is called a targeted synthetic small molecule, and this specifically inhibits an enzyme called Janus kinase. So even though this is an oral therapy, it's actually more systemically active and immune suppressive in its activity. So let's focus more on corticosteroids. As I mentioned, it was a revolution in the management of Crohn's disease and ulcerative colitis when it was discovered that steroids could treat these conditions. And they have been demonstrated repeatedly to be effective for inducing remission or at least controlling symptoms of both ulcerative colitis and Crohn's disease. Unfortunately, we shortly thereafter appreciated that there were risks associated with steroids, and these risks were worse with higher doses and with longer exposure. The risks include an increased risk of infection, psychosocial impact in terms of how it affects people's ability to sleep, either falling asleep or staying asleep. It can affect mood and make people more irritable or even trigger anxiety. And there can be other neurological changes or changes in physical appearance, including weight gain, skin fragility, which makes it more sensitive to injury, acne, or swelling. These side effects are especially noticeable when people have been on higher doses of steroids for a long time. Short doses of steroids or lower doses do not have the same effect on the body. There's also been a well-described effect on development and growth in children who are exposed to steroids too long. And we also know that people who've been exposed to steroids lose bone density and may be at increased risk for fractures. That's especially true in older individuals who are on steroids. It has been recommended that when patients are on steroids for any period of time longer than 2 weeks, that there is a period of time where they're tapered off of them rather than stopping them abruptly. Unfortunately, the taper schedule is not truly scientific and often goes on much longer than is needed, and we'll return to that message shortly. There are a variety of different types of steroids, whether they're oral, intravenous, or delivered rectally. And you can see some of the names there listed with some helpful icons so you understand whether they are oral or rectal. Budesonide is a type of steroid that, although it's taken orally or can be delivered as a foam in the rectum, has very limited systemic toxicity. The drug is essentially active on the lining of the bowel, and any amount that gets into the bloodstream is immediately cleared from the body. So budesonide at the doses that we use it is a steroid that in Crohn's disease and ulcerative colitis does not have the same side effects as prednisone. These are therapies that for the most part are for milder types of Crohn's disease and ulcerative colitis. Hydrocortisone, methylprednisolone, and prednisone are the more commonly used oral therapies, as well as rectal preparations that can be used in our patients. And many patients are familiar with prednisone as being the steroid that is most often prescribed. It has been recommended that when steroids are needed and when it's possible, budesonide preparations are used before getting to more systemic or higher doses of prednisone, hydrocortisone, or methylprednisolone. And this is because we want to start with therapies that work predominantly on the bowel before we go to more systemically active steroids. And the safety profile and the better tolerance of these budesonide preparations makes good sense. Rectal steroids are used because when we want to treat the rectum, which is inflamed in some patients with ulcerative colitis and Crohn's disease, we want to get the drug exactly where the disease is, and it makes more sense to treat it topically than to expect that oral therapy may either get to the rectum by getting through the entire intestinal tract, or that we use systemic therapy when a topical therapy in the rectum might be easier. These can come as suppositories that are inserted into the rectum, or as enemas, or as foam. The foam tends to be better tolerated and easier to hold on to. These are also steroids though, so even though there's very limited systemic effects of all these steroids, you should remember that they're still steroids and they're not going to achieve long-term control, and we do want to move beyond them after we get patients on better treatment options. There's a few comments about steroids that I'd like to share with you. The first one is that although steroids are good at controlling symptoms, they do not actually heal the bowel. They actually impair the bowel repair. So what happens is that it reduces the inflammation, but it has a contrary effect in which it's actually inhibiting the bowel from restoring itself. So while they may make patients feel better, they're not often able to get them to a stable place of control. Therefore, we use steroids as a marker of somebody who needs to be on what's called a steroid-sparing maintenance therapy. That means that by the time a patient needs a steroid, we should be thinking ahead to what treatment are we going to use that will keep them in remission and also keep them off steroids in the future. In general, my colleagues and I think that a patient who needs steroids more than once in a year needs to be on a more effective maintenance strategy. In addition, as I mentioned, patients who've been on steroids for longer than 2 weeks at doses at more than 10 milligrams do need some kind of taper schedule. However, most people end up tapering longer than is necessary. The time for tapering is a combination of how long the patient was on the steroid in the first place, but also how long it takes for the steroid-sparing medicine to get up to its full effect. In other words, we use the steroid as a bridge until the new medicine can take over. And this is a very important concept to keep in mind. We often find that people taper very slowly over many, many weeks, when in fact the new medicine may actually kick in within 2 to 4 weeks, and the patient could be safely off their steroids if it's doing its job by that time. Now I'd like to change the topic a little bit and talk about COVID-19, but specifically about steroids in COVID-19. And in order to do that, I want to explain a few things that we've learned about COVID-19 and the risks in patients who have inflammatory bowel disease. The first one is that there have been a number of publications now, as well as a consensus statement by the International Organization for the Study of IBD. And in all of these different documents, we have recommended that keeping the patients with IBD in remission is key to keeping them healthy during the pandemic. The last thing we want is for patients with Crohn's and colitis to have a relapse of their disease and require hospitalization or require to be put on steroids to get that under better control. As you look down this table of the different medications, you can refer back to what I already described as the different types of therapies we use. And you can see in the far right column what the recommendation is based on the different types of therapies. For example, the aminosalicylates, which we don't think have any effect on our immune system, it's been recommended you stay on them and you take them as prescribed through the pandemic. In addition, the immunomodulators, the biologics, and the JAK inhibitor, that oral small molecule therapy, we've recommended that patients stay on them during the pandemic unless they get infected, and we'll come back to that in a moment. It's been recommended and it's been observed that these therapies are safe and stable for patients to be on during the pandemic. You'll note, though, that steroids are the exception in which the consensus opinion and the emerging data support that patients who are on higher doses of steroids should be off those steroids safely in order to be protected from potential adverse events if they get infected with the coronavirus. This is not new from our general recommendation about steroids anyway, so it makes good sense to keep that in mind. If you are on steroids for your inflammatory bowel disease right now, you should be having conversations with your healthcare team about how you can safely get off of them. And lastly, for antibiotics in general, we think those are safe to stay on if you need them. And again, those are for specific types of Crohn's disease mostly. In order to understand COVID-19, I wanted to share this helpful graphic. I just want to point out to you that there are two main phases of the infection with the coronavirus. The first phase, which is listed here as stages 0 and stage 1, is when a healthy person becomes infected with this novel coronavirus, SARS-CoV-2. The infectious phase of COVID-19 is when someone feels like they have the flu. They may have a fever, a dry cough. They may even have digestive symptoms, headache, or loss of taste and smell. This is what is the most common symptoms that patients will have, and many people, including patients with IBD, will recover from this uneventfully. The later stages is the second major phase. It's the inflammatory phase of COVID-19. This is where people get into trouble. Some individuals have the infectious phase become an inflammatory phase where the body's immune system is making too many inflammatory proteins, and this is what results in pneumonia and lung congestion, shortness of breath, hospitalization, intensive care units, ventilators, and sometimes death. The inflammatory phase is just like the overactive inflammatory phase of Crohn's disease and ulcerative colitis. So it's been of great interest to us to learn that some of the medicines we use to treat Crohn's and colitis may actually reduce the complications seen in the inflammatory phase. It's a very important concept, and it's also important to keep in mind these two different phases. the infectious phase, where someone has the virus and feels like they have the flu and may recover uneventfully, and that inflammatory phase, which happens less often but is much more dangerous. There have been a number of different studies on steroids related to the coronavirus infections and specifically related to COVID-19. There was a severe acute respiratory syndrome epidemic that occurred in 2002 and 2003. That's now referred to as a virus called SARS-CoV-1. It was the original SARS-CoV. And what they learned in that particular epidemic was that steroids made the disease worse, and patients seemed to be more susceptible to complications from the virus when they were on steroids. They also learned that steroids resulted in slower clearance of the virus from the blood and even a higher rate of death. And this wasn't just IBD patients at all. This was the general group of people, because when they developed this severe acute respiratory syndrome, the doctors tried treating them with high doses of steroids and they didn't work. And in fact, it seemed to make patients worse. However, more recently, and you may have seen this in the news, there was a randomized study performed in the United Kingdom where patients who were already hospitalized and needing oxygen or mechanical ventilation received a steroid called dexamethasone, and they were actually able to do better than those who did not receive dexamethasone. And the distinction between what was seen in the SARS, the original coronavirus, and what we think is true for this coronavirus, and what was found in that UK study is dependent on the phase in which we might have treated those individuals. In other words, when you're on steroids, when you get infected, you may actually do worse. But if you use steroids further down the line when you're in that inflammatory phase, it may have some benefit. And I wanted to point that out to you because that's led to some confusion about the messaging regarding steroids in our patients with inflammatory bowel disease. Now, a couple of recommendations regarding how to handle this in terms of your management and considerations if you've been tested. If you find out that you have SARS-CoV-2, but you have yet to develop any symptoms of COVID-19, I hope you don't develop any symptoms of the COVID-19 disease. But if you test positive because you were exposed to somebody, or maybe at work you're required to be tested, the recommendation is, if you're on steroids, to make sure that you work with your healthcare team to get to lower doses. And if you're on other immune modifying or immune suppressive therapy, you actually stop them for a couple weeks to allow your body to either develop the COVID-19 and hopefully recover quickly, or to not develop it at all. And after 2 weeks, you usually know that that is or is not going to happen. If you stop the therapy, it should be under your doctor's recommendation and observation. And of course, you should be communicating with them. In terms of when you would restart the therapy, well, if 2 weeks go by and you haven't had any problems at all, you can restart your therapies safely. If you did develop COVID-19, the consensus recommendation is after 3 days with no symptoms, that includes no fever, you can restart your medications safely. Now, there's a little bit of detail here that's worth mentioning. Many of the medicines you're on, whether they're biological therapies or those oral immunomodulators, have half-lives that make them longer lasting in your body. In other words, even if you stop it for a week or two, the medicine's still there. So it doesn't always make complete sense that you'd be off your medicine for 2 weeks when we know the medicine is still in your system. Nonetheless, that's our current suggestion. There are ongoing studies that so far have shown that some of these medicines may actually be used to treat the more severe COVID-19. And it may come to be that in the future, we won't have patients stop their medicines during this at all. I also hope that in the future, when we have a vaccine, this will all be a moot point and we won't even be worried about it any longer. If you do develop COVID-19, as I mentioned, you should be communicating with your doctors, you should be working with your healthcare team, and obviously focusing on your recovery from this infection and the consequences of it are really important. And I've already gone through what you should do with some of your medicines. It's the same as if you tested positive for the virus but didn't have any symptoms of COVID-19. It's important to know that in the large international registry of patients with inflammatory bowel disease who developed COVID-19, we've learned that the main risks of having problems are related to the same things we've seen in the non-IBD population. More specifically, we're up to over 2,400 patients in this worldwide registry, and being older than 65, having other comorbidities like high blood pressure, diabetes, or heart disease, or possibly lung disease, and possibly being overweight. If you have more than 2 of those, you are at higher risk for having problems with COVID-19. And being on higher doses of steroids at the time of diagnosis are all associated with a greater likelihood of having worse outcomes. When you don't have those comorbidities, and if you're young, regardless of having Crohn's, colitis, a J-pouch, or an ostomy, your outcomes are like the general population, meaning most people recover uneventfully and do just fine. And so this very important international registry has educated us quite a bit about who gets this and what risk factors they may be. And for the most part, it's been really reassuring. In fact, one of their analyses demonstrated that patients who are on anti-TNF therapies, like infliximab and adalimumab, were less likely to end up with certain bad outcomes, again suggesting that they may actually protect against that inflammatory phase of the illness. The general recommendations remain the same as what you've heard on the news, and they're really important because they work, and we try very hard not to politicize public health measures. Wash your hands carefully and learn how to wash your hands correctly. Many people forget to wash certain parts of their thumbs and in between their fingers. Do it properly. Stay at home if you can, and if work will allow you to do so, and do telecommuting as well as other virtual ways of having meetings whenever possible. Wear a face mask when you leave your home. Even if you live in a place where many people are not doing so, it is currently the best way to protect yourself, and if you're sick, to protect others. Make sure you're practicing social distancing, whether you're at work or in other places. Don't get into a crowded elevator, and avoid crowded situations where you're not going to be able to have that kind of distance. And remember that you want to keep surfaces clean. That includes if you touch surfaces like door handles or elevator buttons, make sure that you're sanitizing your hands afterwards, or use something else to push or hold those handles and buttons. And make sure that you learn the proper way to cough and sneeze into your arm rather than into your hands, or certainly not into the air around you. So to summarize, there's a few recommendations regarding COVID-19 and our inflammatory bowel disease patients and steroids. And for the most part, we've learned quite a bit, and I think that overall this is to be reassuring. Follow social distancing recommendations and practice good hygiene. Wear a mask when you're leaving your home. Stay on your inflammatory bowel disease medications so that you can stay in remission, and be reassured that the medications we use to control your IBD may in fact protect you from certain outcomes from COVID-19. Of course, notify your IBD healthcare team if you test positive for SARS-CoV-2 or if you develop symptoms of COVID-19. And remember, one of the main messages of this presentation is that while steroids were revolutionary for the control of inflammatory bowel disease, we've learned that using them long-term is not acceptable even before a pandemic and certainly during the pandemic. And you should be having communications with your healthcare team and with an IBD specialist about getting on medicines that can keep you off steroids and keep you healthy long-term. I encourage you to visit the wonderful Crohn's and Colitis Foundation's website at www.crohnscolitisfoundation.org for more information about all of this, but specifically their very helpful coronavirus website. Thank you very much.